This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1246, recorded on August 21st, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Who's got a red and white markings on your tie. Is that like anthrax?
I think when it's zoomed in, the high resolution people see this as H. pylori.
My.
So really a microbe with a great history. Not a virus. Not a virus.
No, it's not a virus, but it causes ulcers. And the guy who proved that drank it to prove it, right?
I know. He sort of self-fulfilled the Koch's postulates, right? So
Yeah.
isolated it, cultured it, gave it to himself.
So in the past, they used to cut out ulcers surgically, and that eliminated all that, right?
It really, I remember, so I went to medical school last century, in the early 90s. And the class on ulcers had always been taught by a surgeon. And he started the class by saying, I will not be talking about H. pylori. And, it's kind of the last time I think that class was taught by a surgeon because, previously places like the Mayo Clinic, I mean, that was what they did. They did these pretty crazy surgeries where they cut out part of your stomach. They would cut the vagal nerve that supplied the stomach. And then basically it became like, no, actually just 2 weeks of antibiotics and, you're all better. So kind of crazy, right?
Yeah. No, I had relatives who had ulcers cut out. Yeah. And then later other relatives who took antibiotics, and that was it. It's great.
No, it really is. And not only, the issue with ulcers, but also an association with cancers. Yeah. So
the antibiotic will prevent the cancers as well.
Yeah. Yeah. So you get rid of this bug, and then you get rid of the ulcers. You reduce the risk of the cancers. So
fabulous. Yeah. That's great basic medical science, right?
It really is, and it's translated into just such great benefits for so many, so many individuals.
Love it.
Well, let's jump in, and I think that this quote's appropriate for some of the stuff we're gonna talk about today. It's from Mary Shelley, who wrote that classic book, Frankenstein. No man chooses evil because it is evil. He only mistakes it for happiness, the good he seeks.
I don't know if I believe that, Daniel.
Yeah, it's almost like too optimistic a spin. I think there are some folks who actually believe that they're just cruel, evil people out there who just take pleasure, right, in other people's suffering and take pleasure in being cruel and unfortunately, we've touched a little bit, and we're gonna get to an email at the end, so we'll revisit this again. But just there's consequences to all this anti-science rhetoric, right? I think I shared that when I was at a conference last winter with Peter Hotez, and Peter couldn't even cross the street without like armed security. He and Peter Daszak were doing a lecture, and they had to have armed security not only at the doors but on either side of the podium. A lot of people not only get death threats, but we had that attack at the CDC, and instead of sort of stepping up and trying to do something about that, if anything, we hear today about hundreds of CDC employees who have sort of had their firing now made official and permanent. So. We try to talk about what's going on here, but there's real consequences to all this. I'll call it hate speak.
Well, the CDC shooting, right? Police officer killed, many rounds fired. That was a guy who thought he was harmed by the COVID vaccine, right?
Yeah.
And again, probably listening to the anti-vaccine rhetoric that's promulgated by these people who don't know anything, RFK Jr. and his ilk. And so that has consequences, right?
It really does. It really does. And to get to the point where I'm not sure that security guard had anything to do with anything, right, as far as what this person was upset about. yeah, I really think this is tough. Yeah, as we pointed out, like these vaccines, the science, the evidence, very, very clear, have saved the lives of millions of individuals, kept millions and millions of individuals out of the hospital, prevented tens of millions of cases of long COVID, just done so much good. And yeah, there are, like all vaccines, there are a certain number of people that actually had adverse reactions, and we have a system for that. And and that was something that we've discussed as well. There's the study going on at Yale that I've been a part of, helped recruit for. So no, I mean, we sort of eyes wide open here on these vaccines, but there needs to be honesty. I think that, this man may have suffered harm from the vaccine. I do not know the details of his situation, but that's not the CDC's fault. That it's not the fault of the hardworking people at the CDC who provide us with information and guidance. Certainly not this security guard's fault who is actually there protecting people, and they're in harm's way. So, all right. Well, let me read. Do you want to read this letter right up front here? Or I read this. Well, good afternoon. While listening to this week's clinical update, I was annoyed and disappointed to hear no mention of the violent attack suffered by the CDC on August 8th. The lack of widespread media coverage is not your fault. However, I did think there would have been enough coverage for you to at least heard of it. Since you seemingly aren't aware, a gunman opened fire on CDC, firing 500 rounds, nearly 200 of which struck 6 buildings on campus. His presumed motive was a belief that he had been injured by the COVID vaccine, obviously stoked by the mis- and disinformation spread by many, including our own HHS secretary, whose own reaction has been disappointing, as I'm sure you could guess. Tragically, a police officer was killed responding to the event. I have attached a fairly comprehensive news article below. We can leave a link into that. While I cannot speak for the measles response, whose lack of updated website you criticized during this episode, it's not a stretch to consider that the update may have been delayed due to many people across the agency taking leave to attempt to process this trauma. We are public health workers, have felt under attack for years at this point, but this was the first physical attack on us. This message is sent in a personal regard and does not reflect my position as a CDC employee, but I still request that you keep me anonymous if you choose to read this on air, which we will do. Now, this is really, bringing it up so our listeners, if they may not have heard about this, I suspect our listeners are those that have actually heard about this as we had. And really, this is just... it's horrible. It really, really is horrible. All right. Moving on. This is, I was thinking after I read this that maybe I would put like a quotation in from Jaws, right? We need a bigger boat or something. But this is being in the water. Department of Public Health alerts public to rare Vibrio vulnificus bacteria in coastal waters. And I thought this is worth a quick read. So here we go. This is from mass.gov. The Massachusetts Department of Health is alerting residents and visitors to the potential danger of Vibrio bacteria in coastal waters. The alert is being issued after the identification of an extremely rare case of Vibrio vulnificus infection in Massachusetts, which the individual likely acquired from exposure to coastal water at a beach on Buzzards Bay. There have been 7 confirmed Vibrio vulnificus cases among Massachusetts residents in the last several years, including 4 that were likely exposed in Massachusetts. Vibrio vulnificus infections are more common in the warm waters of the Gulf Coast, and Louisiana and Florida have reported unusually large numbers of cases this year. Vibrio bacteria normally live in warm, salt, or brackish waters along the Atlantic coast, said Public Health Commissioner Robbie Goldstein. Heat waves and above-average water surface temperatures create favorable conditions for Vibrio bacteria to grow, making May through October generally the peak season for these bacteria. People with open wounds who spend time in the water or those who consume contaminated shellfish can develop an infection when the bacteria enter the blood. Sometimes these infections can spread through the bloodstream and cause severe, even life-threatening illness. Several species of the Vibrio bacteria can cause human illness, and they give a whole list of Vibrio vulnificus in there. Now, in Massachusetts, between 2015 and 2024, there were an average of 88 cases of Vibrio infection per year. Most of these infections were the result of people consuming shellfish contaminated with the bacteria.
So what kind of illness do you get, Daniel, from these Vibrios?
So some of the cases that I've actually seen have been fulminant sepsis, particularly in people that have liver compromise. Yes, this create a bacteremia. It actually, people can die from this. It can get in the bloodstream, as they mentioned. All right, ivermectin, Vincent.
Wow, the wonder drug, right?
Ivermectin. What is it good for? And I think there's a song by Edwin Starr with, I think, the chorus, absolutely everything, right? No, it's not absolutely everything. And I'm going to suggest that there's a time and place for this anti-parasitic and insecticide medicine. And so we have this article, Ivermectin to Control Malaria, a cluster randomized trial published in the New England Journal of Medicine. And I covered this on Puscast as well, getting lots of attention here. So this study, they conducted a cluster randomized trial in Kwale, which is a county in coastal Kenya in which malaria is highly endemic and coverage and use of insecticide-treated nets are high. Clusters of households were randomly assigned 1-to-1 to receive mass administration of ivermectin or albendazole once a month for 3 consecutive months at the beginning of the short rains season. Children 5 to 15 years of age were tested for malaria infection monthly for 6 months after the first round of treatment. Primary outcomes were the cumulative incidence of malaria infection, that's assessed among children 5 to 15, and of adverse events. A total of 84 clusters comprising 28,932 eligible participants underwent randomization. Baseline characteristic participants were similar in the trial groups. 6 months after the first round of treatment, the incidence of malaria infection was 2.2 per child year at risk in the ivermectin, 2.66 per child year at risk in the albendazole group. So we're seeing about a 26% lower incidence of malaria infection when you get ivermectin versus albendazole. No safety concerns. Got some nice visuals here. We can see the difference, but I was left with a couple questions, right? So Vincent's probably you're focused on the figures, I hope.
Yeah, I wanted to know though. So albendazole is typically used for malaria, not that I know of, right?
Not really for malaria. So this is part of a mass drug administration. So yeah, you're not really, albendazole we don't think of as an anti-parasitic or insecticide. So
what are we comparing this to? What would be the untreated?
Yeah, in a sense, the albendazole is the untreated. So they're saying for part of our mass drug administration, instead of giving albendazole, which we might do as an anti-parasitic for like ascaris and hookworm and other things, we're going to swap in ivermectin and we're going to look, you probably want the other, which is, oh, and by the way, what happened? Like, was it as good for ascaris and, and hookworm and the other soil transmitted helminth? So yeah, that was sort of, think of it that way. So it does become an issue. So are we using ivermectin in terms of malaria as an anti-parasitic? Or are we really using it the way we kind of treat our dogs? We give our dogs these ivermectin, and it's supposed to like actually work as an insecticide, right? Sort of like the deworming and the drug for like fleas and ticks and everything else. So, these results actually stem from a protocol that was approved by the WHO Vector Control Advisory Group. So I think that gets you thinking what might be going on here. There's this community-wide benefit with ivermectin, so not just the people who are getting it. So I do think there's an insecticide component here, but I actually think we've got two things going on. So the ivermectin may be playing a role in the targeting of the mosquitoes, but also ivermectin is an effective anti-parasitic that targets several stages of the malaria parasite's life cycle. So maybe we're getting kind of a 2-for-1, but I do worry about resistance with these mass drug administration approaches. All right, so I want to, in real time, I'm going to see if these Legionella numbers are actually up to date. So right here, let's see where they are relative. So I'm going in real time. In real time, I'm seeing 111 confirmed cases. We're up to 6 deaths.
No.
So as of August 21st, I'll put in the August 21st. So August 21st, yeah. So just the reason I'm doing this in real time is that this is something that's sort of ongoing, developing. And I was listening to TWiV, Vincent. I listened to all the TWiC's
Wonderful
episodes.
So you're all the people who listen. It's just you, nobody else.
I'm not the only one who listens to all the TWiC's things. But yeah, I was listening to This Week in Microbiology, and there was a little bit of a discussion about Legionnaires. I mentioned I was a little bit pessimistic about the fact that they were going to quickly get this under control. And now 2 deaths later, I'm hoping that we do move a little bit forward on this. But it does sound like they've actually identified some of those cooling towers, like 11 of 12, I think was the number, contaminated, cleaning them out. So we're hoping we're going to end up not seeing more confirmed cases. No confirmed cases. Well, no cases, actually, hopefully. No hospitalizations, no more deaths. Actually, I've got a gentleman in the hospital right now who actually has Legionnaire's disease. He's doing well, by the way. Ended up with some heart issues this morning. His heart rate was like 150 when I saw him, but that was the AFib. But not a virus, but I did think let's talk a little bit about Legionella and the history, because I thought it was interesting when it came up. So what do we know about Legionella? So there's really 2 diseases that we talk about with Legionella. We talk about Legionnaire's disease, or Legionella pneumonia. That's one. The other is Pontiac fever. And in a sense, one came before the other, but we didn't know the other what it was until after the second. So go back to 1968. So in 1968, there's this city, Pontiac, Michigan. And a bunch of people, it's like over 100 folks that are either working at or visiting the county's Department of Health, come down with fever, mild flu-like symptoms, no pneumonia. So a bunch of them get sick, nobody dies, nobody goes on to progress. They're not really sure what it is. They draw a whole bunch of blood. They take samples of the environment. They've got water samples. They've got all the rest, and then just years go by. So now it's 1976. And the American Legion members, that's who those guys were, the Legionnaires, the Legion. They're celebrating something. It's 200-year anniversary of something.
Yeah, the U.S., 1976.
So that's how you can remember. So it's
the bicentennial,
1976. It's the bicentennial. I remember the bicentennial, and the tall ships came into New York Harbor, right? That's why I remember it, because, big tall ships. So they're down there celebrating in Philadelphia. Bunch of them get sick. Bunch of people die. They do a whole investigation. They actually figure out that it's caused by this newly identified bacteria, Legionella. They actually then go back and they figure out that disease in 1968 was due to Legionella. And probably, because it was only in 76, 77 that this bacteria was identified, that serology testing was developed. Legionella has probably been going on for a while. We just haven't figured it out and hadn't figured it out. And we still, to this day, we probably miss a lot of cases because we'll often test for Legionella by using a urine antigen, which only picks up one serotype. It's only maybe 50% sensitive. We say it's 99% specific, but like places like the city, they actually are really encouraging people to not just do the urine, but also send off sputum and other testing as well. So
I don't know, Daniel. I like the name Pontiac fever better than Legionnaire's disease, but I guess the people of Pontiac don't want to use it.
Well, it's important to realize there are 2 different diseases. So Pontiac is Pontiac fever is Legionella infection without pneumonia.
I see.
And Legionnaire's disease is Legionella infection with pneumonia.
So Pontiac is infection of the lungs also?
No, it's more of a systemic infection. People get sick, they feel crummy, they have fever. You do a chest X-ray, you listen to the lungs are clear.
How is that acquired?
We also think it's acquired the same way. We think you breathe it in, right? And the bacteria, the Legionella bacteria, are living in the amoeba and the paramecium. You breathe in the amoeba and paramecium from contaminated water, which when they went back, they were able to grow the Legionella from some of the water samples from 1968. You breathe it in, and then it may have something to do with the host. It may have something to do with the inoculum, right? Because a lot of people in 76 got pneumonia. But again, these are like some older folks, right? And you got to figure the people who are working at the health department are not like, these Legionnaire convention folks. So, and how you treat it? You treat it with a Z-Pack, little maybe extended out to 10 days, and maybe a fluoroquinolone like Levaquin. So usually easy to treat, but the big thing is making that diagnosis. And I think I have to say, I mentioned many times when I trained, it was underappreciated that this was actually a pathogen to even consider in the tri-state area. All right. News release, the American Academy of Pediatrics releases its own evidence-based immunization schedule. They always do this, right? They always release their own evidence-based immunization schedule. It's just now it's news. Why is it news? Because we read, as respiratory virus season approaches, the American Academy of Pediatrics has published an evidence-based immunization schedule that includes updated guidance for influenza, RSV, COVID-19 immunizations for children and adolescents from birth to age 18. Now, as I mentioned, since its founding in 1930, the American Academy of Pediatrics has been a leading voice in vaccine recommendations, creating evidence-based guidance to support pediatricians in caring for children and families. The schedule, published this last Tuesday, continues in this tradition. It differs from recent recommendations of the Advisory Committee on Immunization Practices of the CDC, which was overhauled this year and, I read, replaced with individuals who have a history of spreading vaccine misinformation. Here we go.
Right.
I think it's disinformation, right? I think they're doing it on purpose.
It's disinformation, yes.
Yeah, it's really disinformation. This isn't just like, we made a mistake. They have an agenda. So, okay. So they give us some recommendations. I'm going to touch on the ones for RSV, influenza, and COVID, right? So RSV, basically point out that RSV is the leading cause of hospitalizations for babies before their first birthday. Huge problem. And as we know, babies who become infected with RSV can get much sicker than older kids because their lungs and airways are so tiny. There are two ways to help your baby get ahead of this serious respiratory illness. Moms who get the RSV vaccine during their pregnancy, or new babies can get an RSV shot for RSV season. And we've got those two monoclonal antibodies, nirsevimab and clesrovimab. And then another monoclonal, palivizumab, no longer recommended. So we're moving on. So nirsevimab and clesrovimab. And what do they recommend? Immunization for infants younger than 8 months who are born during or entering their first RSV season if the pregnant parent did not receive vaccine during pregnancy, if the vaccine status is unknown, or if the infant was born less than 14 days after the pregnant parent received the vaccine. Immunization for infants and children 8 through 19 months of age at high risk of severe RSV disease and entering their second RSV season. Influenza across the board, AAP recommends annual flu vaccines for all children starting at 6 months old, unless they have a medical reason not to be immunized. That's in line with the fact, we're going to get into this a little bit later, 270 children died of the flu last flu season, 270. The majority of those were completely healthy. The majority of those were not vaccinated.
I saw Paul Offit being interviewed on CNN about this, and a lady, or was it PBS? Yeah, PBS. She said, 250 children. Do we have to immunize all the children just because of that?
Oh my gosh.
Yes, we do.
Oh my gosh. 270 children died. Thousands ended up in the hospital. 20% end up in the ICU. Oh my gosh. Yeah.
So what were the ACIP's recommendations?
They're basically not recommending, vaccines for children unless they have these comorbidities. They seem to have this whole agenda that unless you've got, and as we keep pointing out, it's half of these kids, they're healthy kids. You can't identify them by, just saying you have to have risk factors. And then COVID, that's the big one, right? COVID continues to result in hospitalization and death in the pediatric population. These over 150 children died of COVID. Thousands of kids ended up in the hospital. Infants, children, age 6 through 23 months, they actually really have the same risk as someone over 65. So given this, the American Academy of Pediatrics recommends a COVID-19 vaccine for all children ages 16 through 23 months to help protect against serious illness. Now, they're going to make a slight change here. The AAP recommends a single dose of age-appropriate COVID-19 vaccine for all children and adolescents 2 through 18 in the following risk groups. So persons at high risk of severe COVID, residents of long-term care facilities or congregate settings, persons who've never been vaccinated, persons whose household contacts are at high risk for severe COVID-19. So you're starting to get almost everyone here. But what they do is they also say that the AAP also recommends the vaccine be available for children aged 2 to 18 whose parents or guardian desires them to have the protection of this vaccine.
Daniel, is this just a one-shot deal, or is it an annual vaccine they're recommending?
So the whole idea with COVID shots now is this annual shot. I mean, when you're younger, the 6 through 23, there's this sort of schedule for getting that initial series in. But then after that, it's a shot once a year for everyone, except that little twist. If you're over 65 or a high-risk group, then there's maybe a second shot. All right, measles, we did get an update. And it's disturbing, I think, if the reason we didn't get an update last week was because people were, trying to recover from the fact that, there were hundreds of bullets being fired down there in Atlanta. But we do have an update. And as of August 19th, a total of 1,375 confirmed measles cases. We're now up to 42 jurisdictions. So we're seeing more cases, and another jurisdiction was added to the list. Canada, we're up to, this is week 32, so up to August 9th. So 94 new measles cases, 4,638. I do want to sort of broaden, our scope when we talk about measles this week. So 2 deaths due to measles in Israel just this last week. It was the death of an 18-month-old toddler who contracted measles. Unvaccinated boy arrived at the emergency room in Jerusalem, being ill for several days. He went on to die. We recently had a 2-year-old unvaccinated boy who died Wednesday. This is last week, Wednesday. We read that since the measles outbreak began in Israel about 3 months ago, 526 cases of measles, 209 are currently active. So it's really ongoing. Most of the recently diagnosed patients are from the Jerusalem and the Beit Shemesh area, with most of the hospitalized patients being unvaccinated children. As of last Thursday, 19 children still hospitalized, all under the age of 6. 2 of the children are in the ICU. 1 is connected to a life support system. Pan American Health Organization is actually urging countries in the Americas to strengthen the immunization activities. As of the 8th of August, a total of over 10,000 confirmed measles cases and 18 related deaths have been reported across 10 countries, 34-fold increase compared to the same period last year. Countries with the highest case numbers: Canada, 4,548, Mexico, 3,911, the U.S., 1,356, and then other countries, Bolivia, Argentina, Belize, Brazil, Paraguay, Peru, Costa Rica. And, number of deaths: 14 deaths in Mexico, 3 in the U.S., 1 in Canada. All right, flu. We're still getting close to a flu vaccine period. But I did want to give an update on the pediatric deaths, right? So we're still kind of counting how many pediatric deaths occurred during this last season. We're up to 270. This is clearly the highest number of pediatric deaths reported in any non-pandemic flu season since this season, since the condition became reportable. And I've got a graphic here. I'll leave a link to cdc.gov/FluView/surveillance. You can actually just see over the last few years. So 2021 to 2022, 49 pediatric deaths, but then the next year, 187, the next year, 209, and now this last year, 270 pediatric deaths. Almost all these kids are unvaccinated, and about half of these kids, no underlying medical issues. They just got the flu and did not survive. All right. So I will leave in the recommendations. But one of the recommendations, what if, moving from the little kids to the older folks, what if you are 65 or older? What flu shot should we get? Should you get? Should they get? I'm under 65.
The one that you can get, Daniel.
Well, it's really interesting, right? Because this is like the recommendation is funny. So the CDC has these recommendations, right? So they're going to say, oh, these are the ones you want. But yeah, if you can't get those, just get anything. So ACIP recommends that if you're 65 and over, preferentially try to get yourself a high-dose inactivated influenza vaccine. That's the HDIIV3 or the Fluzone high dose. Sarah Dog and I were trying to figure out what that II or Roman numerals. So it's inactivated influenza, right? II. Okay. You can get your recombinant influenza vaccine. You get your adjuvanted inactivated flu vaccine. Or, yeah, if none of those are available, then just get anything else that's available. It's like, yeah, can't you like call ahead of time and say, because does it matter? Does it matter? Well, let's read the following article. It does matter, actually. So we have the article, Relative Effectiveness of High Dose versus Standard Dose Influenza Vaccine Against Hospitalizations and Mortality According to Frailty Score, a post hoc analysis of the DanFlu-1 randomized trial published in JID. So the results of a post hoc analysis of the randomized feasibility trial of high dose inactivated influenza vaccine versus the standard dose conducted during the 2021 to 2022 flu season, older adults 65 to 79. They're going to look at vaccines in folks with like different frailty scores. They're going to look at incidence rate ratios. Basically, I'm just going to say across the board, the high dose was associated with a lower risk of first and recurrent hospitalizations for pneumonia and influenza compared with standard dose, irrespective of frailty status. And we actually see pretty nice, in the low frailty population, we're seeing a hazard ratio of 0.37, so about a 63% reduction. We move into folks with, intermediate or high, we're seeing a hazard ratio of 0.33, so about a 67% reduction. So we're basically seeing we're seeing benefit here for hospitalizations. We're also seeing benefit here for all-cause mortality. There, it was about a 74% reduction. So seems like getting that high-dose flu vaccine really makes a difference. So call around, try to get one of the recommended. I will leave in a link. We will leave in a link to the CDC recommendations. What are those ones? So ask for that high-dose, that recombinant, or that adjuvanted flu vaccine. What do you think, Vincent?
I think it's clear that it makes a difference, but I can never get it.
You got to shop around, right?
I don't have time to shop around. I'm doing podcasts, Daniel.
Well, if you don't take care of yourself, you won't be able to do any of that podcasting. So make the time. Make the time. All right, RSV. So we got a question about RSV and GBS. So what's the story? I'll give kind of an update here. Leave in a nice link to CDC where they actually go into this. So currently, what is the recommendation with RSV vaccine? What's the story with Guillain-Barre syndrome? Right now, CDC is recommending everyone age 75 and older get that RSV vaccine. If you're 50 to 74, you get it if you're at increased risk of severe RSV disease. It's not an annual vaccine. So at this point, you get an RSV vaccine, and then we're kind of waiting to see if there'll ever be a point that you need to get it again. So it's a one-time dose. We've got 3 options out there licensed by the US FDA. We've got GSK's Arexvy. We've got Pfizer's Abrysvo. And then we've got Moderna's Mresvia. That's an mRNA one. So what happens with Guillain-Barre? So in clinical trials, a small number of participants aged 60 and older developed serious neurological conditions, including GBS, Guillain-Barre syndrome, after receiving GSK's Arexvy and Pfizer's Abrysvo. We read GBS is a rare condition in which your immune system attacks your nerves, causing symptoms such as weakness. For both vaccines, the FDA estimates the risk to be on the order of 7 to 9 excess cases per 1 million vaccinated adults 60 and older. No reports of GBS among adults who received Moderna's Mresvia vaccine. All right. I'll leave in links. All right. COVID. We're actually seeing high when we look at the wastewaterscan.org. And when we look at the CDC national trend, I think that's very clearly heading up. And in certain parts of the country, we're actually getting up into the moderate zone there. So it looks like it is starting. It looks like it did not go away, Vincent.
I don't understand why it's starting now, right? I mean, I suppose, this week school begins at a lot of universities and colleges, right? So
I mean, this is interesting, right? It started to go up like early August, right?
Yeah.
End of July, early. Well, why? What was going on?
I mean, people are outside in the summer, right? I don't get it.
Yeah. It doesn't make a lot of sense yet. We're still this virus is still trying to figure itself out, and we're still trying to figure it out. You get COVID, you do your test. A lot of parts of the country, those positive test rates are just really high because people, not really showing up unless they have COVID. But again, standard guidelines, not much change here. Early antiviral for folks at risk of progression: Paxlovid, remdesivir, molnupiravir, convalescent plasma. The second week, early inflammatory phase, right? First week, viral replication. Second week, we start seeing the immune system issues, steroids in a certain subset, anticoagulation, pulmonary support, sometimes remdesivir, and immune modulation. But what about the late phase? What happens after that acute infection with COVID? So I'll leave in a few links here, but we're going to close this out with the article, Accelerated Vascular Aging After COVID-19 Infection, the Cartesian study published in the European Heart Journal. And we know this is a study designed by cardiologists because they have a cool name, Cartesian. And they're good at this. I think they sit around. They're like, we're not doing the trial. You don't get the money until you have a cool name. If it's not Copernicus or Comet or Cartesian. But so here we have the Cartesian study. And these results are from a retrospective they say multi-centric. It's a multi-center cohort study. 34 centers, 16 countries, 4 groups of participants. So these are the 4 groups. So first group, COVID-19 negative controls. That's number 1. Now, here are the other 3 groups. These are groups of individuals with recent exposure to SARS-CoV-2. So of these 3 groups, so we'll keep the first one is negative controls. The not hospitalized, that's group 2. Hospitalized in the general wards, that's group 3. Hospitalized in the ICU, that's group 4. So we're going to compare group 2, 3, and 4 to group 1 negative controls. Now, the main outcome is something called carotid femoral pulse wave velocity. And so they say an established biomarker of large artery stiffness. This is really interesting. What they're going to do is they're going to send this pulse wave down the large arteries, and the stiffer the artery is, the faster the pulse wave propagates. This has been validated. The more elastic, right, you're going to get that sort of absorption, so you're going to get slower propagation. So they're going to look at 2,390 individuals, lots of YouTube videos if people want to watch how this is done with the tonometer and the sensors and everything. So after they adjust for confounders, all of the COVID-19 positive groups showed higher PWV. So that's a pulse wave velocity, right? So higher is bad, stiffer. So these people are developing stiffer arteries after they end up with COVID. But here's the interesting thing. When you stratify it, when you look at men versus women, all the differences are in women. We're not really seeing this stiffening of the large arteries in men. We're seeing them in women, and pretty significant. So even more interesting, among the COVID-19 positive women, persistent symptoms were actually associated with this increased stiffness, with this increased PWV, so this is pulse wave velocity. And this was regardless of disease severity, regardless of any cardiovascular confounders. Nice graphical abstract where you can actually see where all these centers are. So US, Canada, Brazil, Mexico, a bunch of countries throughout Europe.
So this is extended to even people who are not hospitalized, correct?
Yeah, so a chunk of these folks, and you can actually see in the graphical abstract, if you look at women non-hospitalized, you're actually seeing a significant difference in this artery stiffening.
What's bad about having stiff arteries, Daniel?
So it's actually considered part of vascular aging. So over time, what will happen is as we age, our arteries will get stiffer, and this is associated with hypertension because every time your heart beats, instead of it being able to sort of absorb that and then like slowly dissipate, you end up developing hypertension, your increased risk of strokes and heart attacks and all kinds of cardiovascular issues.
You think this also happens after influenza and RS infection?
I'm curious, right? I mean, now that we're seeing this, and this is a non-invasive technology, so you can start asking, like, what happens after flu? What happens after RSV? What happens after all these other infections?
And also if vaccination mitigates any of it.
That's great, right? I mean, that's really the next, when you start breaking that out. Can you protect yourself against this? Because we've talked a lot of times, right, about this connection between different viral illnesses and increased risk of cardiovascular problems afterwards. So there's tremendous amount of research that can be done here. All right, so no one is safe until everyone is safe. Here we are. We're getting to the end of August, getting to the end of our first month of our American Society of Tropical Medicine and Hygiene fundraiser. We'll be doubling your donations to get up to, hoping to send the maximum donation to them of $20,000. So go to parasiteswithoutborders.com, click on that donate button, help us to support them and help us do what we keep doing.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Our first email is from Richard. As you noted on Clinical Update, the CDC failed to report on the current cumulative number of measles cases in the U.S. Would like to review the events surrounding this outbreak and point out a few related circumstances that may be pertinent to the subject of the CDC response, and in particular to validate my own sanity. This reporting was first limited to once a week on Fridays, as opposed to daily, as Junior was taking criticism over his casual approach toward the 2 deaths of the girls in Texas and a single death in Mexico. Conveniently, this Friday reporting provided a 72-hour cushion in a 24-hour news cycle, further dampening the effect of this infection data. Reporting might be generated by a once-a-week reporting protocol. More recently, the report date changed to Wednesday. There's not been any comparison with previous weeks or representation of the increased rate of infection. Now, after another 4 to 8 week period of Wednesdays, the current data is now unavailable. Although, as you said, Daniel, now we got some data.
Yeah.
In the beginning, there appeared to be a rapid increase in the rate of infection up until the time the reports were issued, paralleled that of Canada. Since the funerals of the 2 girls and the scrutiny applied to Junior's lying about measles outbreak prevalence and the first report interval change, the U.S. rate has dropped dramatically and miraculously leveled off, with infections lumbering in the 1,300s. At the same time, Canada, with a robust national health system and a slight lag in data collection, has closed in on 5,000 infections, as you reported this week. It would seem the U.S. should at least have some equivalence with rates in Canada, given our public health system and our vaccine hesitancy. Over the same period, I'd noticed on my X account and Google News a steady drip of anti-vax zeal, replete with dubious half-truth references delivered by HHS directly from his secretarial excellency and his parlor interviewing courtesans. This has been accompanied by the increasing appearance of interviews with anti-vax propagandists, Malone and McCullough et al. All of this has occurred with seemingly increasing intensity, more crazies, and better graphics. They are currently repositioning the goalposts with the current target, alum adjuvant. It leads to wonder if this is algorithm or orchestration. Am I getting this nightmare accuracy? My wife and I just turned 79. We have worked professionally through all the pandemics since '68 in face-to-face proximity to dental patients, with and without PPE and effective vaccination. Though retired, we remain in a high-risk category for the pathogens are under discussion due to age. Many thanks for your dedication to real science. As a second-generation dentist in Southern California, I have been exposed to these crackpot theories for health and longevity most of my life. Scientific clarity has been the only antidote for the disinformation, both in and out of the health professions. Best wishes and keep the faith, Richard.
All right. No, it's a nice email, Richard. I appreciate that. And I do. I mean, at least our hope is that we continue to provide this antidote of information, of science. And I think it's important that, as difficult, as challenging sometimes as these conversations can be, and sometimes as threatening as some of these anti-science people are, that we just continue to have these conversations. We continue to provide the actual truth, the actual science.
Ellen writes, my 77-year-old brother contracted COVID, which became symptomatic a few days ago. He called many pharmacies in New York and New Jersey. No one had molnupiravir, which is internist preferred because of other meds he takes. Finally, the doc said Paxlovid would be okay in a pinch. After many more calls, my brother found a pharmacy up on Dyckman Street that had Paxlovid. Was that up in the Bronx, Daniel?
I'm not sure. I got to check that out.
The bill was $279. My brother, astonished, said he thought insurance would pay most of it. The pharmacist said it would have been $1,200 if he didn't have insurance coverage. Is this a result of the RFK regime?
Yeah, no, I don't know exactly the details, but yeah, this is really tough. I mean, when we have these effective medications and then we have these financial barriers. Left to blame it on RFK Jr., but I'm not sure this actually is directly due to him. We did, there were periods of time when these medicines were completely covered. And there was really this idea that it was cheaper to treat people than it is to let them progress, let them end up in the hospital, let them end up with long COVID.
So Dyckman Street is in the Inwood section of Manhattan.
Okay.
It's all the way up above, Columbia Presbyterian Medical Center.
All right.
Bill writes, just a brief comment on your mention of research in Antarctica. As I made 6 round trips to the Antarctic Peninsula in the late 80s aboard the then NSF chartered research vessel Polar Duke, as well as 3 winters at the South Pole. The vessel involved, Le Commandant Charcot, is in fact a cruise ship, French flag, completed in 2020. It can house 270 passengers. I don't know the exact details, but many cruise ships that visit the Antarctic have lab space that can be used by researchers, perhaps to give them bonus points with the country involved or allow them to get to places otherwise off limits. It was first detected, so bird flu was first detected on South Georgia Island. I've been there in October 2023, and here's a Guardian article and a Nature Communications article. And Bill is Kathy Spindler's brother.
Oh, that's great. Yeah, no, I mean, it did. We were saying it looks like a cruise ship. So that's neat that it is a cruise ship. And then it's interesting that they're working on bird flu on a cruise ship, right? That
Yes.
They mentioned that to the passengers. Yeah, we've got special biosafety. We'll be working on bird flu downstairs. If you feel sick, do let us know. I did get some questions like, how did it get to Antarctica? And my suspicion is, there are these birds like Arctic terns would be an example that migrate, to and from these areas. So I suspect that's probably what happened. I mean, the birds like Arctic terns will go all the way from the Arctic to the Antarctic, back to the Arctic. So it probably was some kind of a migrating bird that brought it there.
Bird flu, Daniel.
That was a good. Did you work? You worked on that, Vincent?
It just popped into my head.
Okay.
Maybe I should have been a comedian.
No.
Oh, he doesn't like my jokes. Okay. Chris writes, love your work on Microbe TV. I know there are a lot of HHS officials waging war on U.S. vaccine programs. I'm a bit confused on what's going on with the important vaccines for 65-plussers like me. Is there an appropriate updated COVID vaccine for the fall 2025 season, or was the advisory committee dissolved or compromised on this subject? What is your recommendation at present? Will insurance companies continue to pay for COVID vaccines? Is there an updated influenza vaccine? And for 65-plus individuals, is RSV needed annually, or is it a one-and-done vaccine?
All right, Chris, we're going to do this in reverse. So the RSV vaccine we went through before. So it's 75 and older. If you're 50 to 75, it's if you have a risk factor. There was that period of shared decision making. So some folks already got that RSV vaccine, maybe outside of those recommendations. So far, it's a one and done. We don't know about revaccination. Interesting, there were some studies where they did revaccination at like 2 or 3 years into it. Really didn't see much bump in the antibody titers, or not much sort of efficacy to doing that. So interesting. We'll learn more about that. So for now, RSV, one and done. Updated flu vaccine, yes. We leave in our show notes sort of what they're going to target. But if you're 65 and over, there's certain vaccines which actually the data would say are even better than the standard. So try to get that high dose, that adjuvanted, that recombinant, that sort of senior version of the vaccines. What about COVID-19? Oh my gosh, yes. Things have been compromised. It is a mess. I actually was checking the other day, waiting to see, are we going to get some updated ones? What's all going to be the fallout? So I'm going to keep everyone updated when we actually have, I'm going to say, vaccines in hand. But yeah, there should be Novavax. There should be a couple mRNA options. So we should have updated COVID-19 vaccines available coming weeks. I mean, it's already getting to be the end of August here.
Okay, we have 2 emails about measles data, getting good measles data if you're not trusting the CDC. So Mark writes, in case you are unaware, Johns Hopkins has a U.S. measles tracker and gives the link for that, with tabs for both cumulative and recent cases. They pull their data from both state and county health departments, over 150 sources. Since many of these data sources are press releases, I suspect there's a lot of human effort to hunt down and gather these numbers. And then Abby writes, I work for a state public health lab and have been using the Pandemic Center report from Brown as a source for measles data in conjunction with, but now as a replacement for the CDC. They scrape state reports to get their data. And this is from last time we said, if anyone knows, can you scrape data from the states? Here you go. This Johns Hopkins and Brown, that's what they're doing. So maybe you could put those links in your weekly update, Daniel, or check them out.
Yeah, this is great, actually. It's interesting, right? So I'm looking at them kind of in parallel. So the CDC site we have as of August 19th, 2025, total 1,375. Hopkins is only giving me 1,366. It's current up to August 18th. So yeah, this is great. I'm gonna leave these in my show notes, and then it'd be great to have multiple sources to look at. Thank you.
And one more from Javad. Hi, love all you do to keep us informed. I am a primary care doctor and professor in Minnesota. I was disappointed to see that the Minnesota Department of Health has been telling our hospital systems not to test for measles individually. They want us to send the test to the department. Does this make sense to you? I feel like this is an unnecessary burden that will make us test less. A positive measles test would have to be reported anyway, but getting the MDH address, the proper packaging, etc., is a big lift for us as primary care doctors. Why not just let us send the test to our lab? I feel like we are missing lessons from the COVID pandemic. One was to make testing as easy as possible. What are your thoughts?
Yeah, Javad, this is actually, I mean, I'm glad you raised this point. We do not want to put barriers. If a clinician is concerned, you want to make it easy to test. You don't want to put impediments in the way. What do we not want to know there's measles until it's spread to a whole bunch of people? No, make testing as easy as possible. Don't put barriers in the way. I completely agree with your concerns.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.